Hello, everyone. We'll give it another minute or so to get a few more people in, and then we'll get started. All right. We are 2 minutes past, so let's get started. Hello, everyone. Welcome to our industry showcase today. We have Unlocking Capacity, a practical framework to reduce health system administrative burden and strengthen financial performance. Today is March 24th, 2026. Thank you all for being here. My name is Madison Lohman, and I will be hosting you today. And I would like to begin by acknowledging the Indigenous peoples of all the lands that we're on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the lands which we each call home. We gratefully acknowledge that we are on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, the Williams Treaties, signed with multiple Mississaugas and Chippewa bands. Please take a moment to share in the chat the territory you're joining from today. And on a technical note, please use the chat or the Q&A if you're having any technical difficulties, and I'll be happy to help you out. We will also have time for Q&A at the end of the presentation, so please submit your questions at any time, and we will get to them towards the end. And today's industry showcase is brought to you by Petal Health. Thank you very much for sponsoring the session and bringing together this thoughtful discussion. Now, it is my pleasure to introduce our presenter today. We have Yan D-Beaurivage, who is the healthcare technology leader focused on helping health systems unlock constrained capacity by addressing administrative burden, system alignment, and finding a way for teams to do more with less. As Vice President of Product, Market, and Growth Strategy at Petal, his work centers on the operational realities that limit hospital performance, fragmented workflows, manual coordination, and disconnected digital systems that suppress throughput, strain clinicians, and erode margin. Leveraging more than 15 years of product development and partnership experience, Yan partners with health system leaders to translate strategy into practical, enterprise-wide execution, aligning clinical operations, digital infrastructure, and financial performance. His approach is pragmatic and system-focused: simplify workflows, eliminate duplication, untap system development, and deliver measurable time to value without adding organizational complexity. So thank you for being here today, Yan, and I will now pass the mic and the screen over to you.
Thank you, Madison, for the intro, and welcome everyone to this session today, where we're going to dive into the topic of administrative burden. I'll admit it is a loaded topic, so I don't have the pretension today to do a full deep dive, but I would like to get the audience is at least one or two concrete tips, insight that you can bring back to your team, help you strategize, help you solve that big problem, and that's what we're going to do today. At Petal, we had the chance over the last year to meet multiple health organizations, health delivery organizations, health authorities, administrators, policymakers as well, but more importantly, a lot of frontline clinicians, including physician, including nurse practitioner. And we've been able to paint a pretty global paint of the problem, the drivers underneath the fundamental problem of administrative burden. And that's what we want to share to you today. My objective is that each of you can get, one or two concrete insight, as I say, tips to come back to your team to help you solve that problem. So take it as a high level view, but at the end, we do want to provide you some concrete insight that you can leverage at the end. So that's sort of the main goal today. So hopefully you're going to find some good insight toward that small presentation. So as I say, the agenda, we're going to start really just by, really delving into what are those challenges, how do they translate into leakage and capacity, and also in well-being of our physicians. And I'm going to propose you a framework which we call the administrative burden reduction framework. really to sort of find concrete action that can help you unlock wasted capacity. And at the end, we're going to sort of bring some thoughts around how can you make that scale, right? So it's okay to to have those to implement those solution or those new elements, but how can you make that scale so that it's sustainable as well? Okay, so that's the agenda today. At first, the administrative burden is real and growing, right? The numbers don't lie. We're talking here based on a recent survey and study from CMA of 19.8 million hours lost across Canada on administrative tasks that could be delegated and completely avoided for physician. That is huge. It is the equivalent of 20, we're talking here of close to 20 million hours of the most critical and limited resource we have in healthcare, right? If we're bringing back from another lens, it's the equivalent of more than 9,000 full-time physicians. I will let that sink for a second. That is focusing on tasks that is not adding value and that could be avoided, right? So imagine yourself as a patient, you're sitting in a room, you're waiting for care. If you look at the workforce in the physician workforce in Canada, this is looking at 10 doctors, and one of the 10 doctors is working full-time on paperwork and red tape that can be avoided. That is huge, right? So that is why, from a number perspective, we know it's a fundamental driver, it exists. And there's actually some solutions, some concrete things we can do to help solve this. I think for anyone working closely with physicians, this shouldn't be a surprise. But I think the other aspect is that number is growing, right? So just 2 years ago, this was just $18.5 million. So it is a problem that is not that only exists, but it is growing. And we're a world where the divide between the demands, the patient demand, the volume of demand, the complexity of the patient demand and care increase, and yet we see a shrinkage in our capacity just from an administrative burden perspective, and we don't have the luxury to create that divide. So this is just to set the stage. It is real, it is a big problem, and obviously we need to find solution to solve that. The other aspect, which is sometimes hidden, we can measure pretty concretely what is the cost of hours lost, due to administrative burden, the number of people that do early retirement or even, burnout due to this burden and cognitive load. What is harder to measure is really the impact on the physician welfare, and then how does that translate into the quality of care? So 60% of physicians report that administrative burden contributes to worsening mental health. And this is obviously for some in some instance contribute to burnout in early retirement. But what about the people that stays in the system and try to do their job and have this strain on them, right? So what is the impact on quality of care and even the throughput of care? So that's something to take also into consideration. There's things that are hard to measure, but also has a huge impact in your capacity to have a sustainable system. So what's at stake? I think the vicious circle here becomes very obvious for anyone in the room. Physicians spending time on administrative tasks, on things that doesn't add value, on red tape, on things that could be avoided, mean less patient care, less patient experience, which is, obviously lead to all the problem we see in the news, delays in care, longer wait time, fragmented journey as well. And this all leads to a big question, right? Is this sustainable as a healthcare system? And what are we going to do about it? Right. So this is the vicious circle we need to look. And today, I hope we're going to obviously give you some concrete element on how to solve at the micro level, but we also got to take a step back and see what do we need to do at the system level to solve this. So what are the drivers? What is driving the burden and the financial strain that we have due to administrative burden? There's many, right? We know that some of the biggest culprit include the health system processes, the insurance company, a lot of paperwork attached to that, government form, the fragmented ecosystem dealing with so many different systems that doesn't talk to each other, and even the dreaded employer sick note, right, requirement, which just by that create a lot of administrative friction. So there's a lot of driver. But today we interviewed a doctor recently, and I think I'm just going to tell this story, what he told to us, just to illustrate very concretely, what are the driver behind that financial strain and burden, administrative burden. For confidentiality purposes, I'm going to just name that doctor who. He's a clinic owner, primary care clinic owner in Ontario. And, let's start. This doctor spends about 1.5 hours daily, including weekends, on paperwork, managing an inbox with lab result, hospital reports, and other messages that require review and action constantly. The doctor faced challenges with information overload, including receiving multiple reports from a single hospital visit and having to examine lengthy specialist report to find relevant information. Dr. Yu used various systems managing incoming information, including Ontario Lab Information System, hospital report manager, and faxes, which are scanned and uploaded by his staff that he's paying out of his clinic pocket. The lack of integration and interoperability between different clinics in EMR system lead to duplicate patient chart and inefficient information sharing when patients visit other clinics for after-hour care, often relying mainly on the patient to provide the complete and accurate information to provide the care. In short, despite the use of multiple systems, there are still gaps in information sharing and efficiency, particularly in cross-provincial or out-of-network scenarios. So what does this all sum up to, right? Limited access to patient record across different clinic and hospital, reliance on fax again and PDF for information exchange, which is not also a very safe way of exchanging information in terms of privacy. There's a lot of risk attached to that. Obviously, duplication of information, data entry, and leading to inefficient workflow and not streamlined workflow. And even just concrete example, e-referral process being suboptimal with only 10% of them being done electronically. And even the digital experience, is not optimal. There's a lot of feedback comes that you need to do a lot of clicks, and it's pretty hard to do the referral even online. So, let's not forget that Dr. is also a clinic owner, and he quotes, "We're a small business. We have to basically bring everything. We pay for the brick and mortar, we pay for staff, we pay for EMRs and everything else. When I'm looking at my total income, I divide it by 3. So the third goes to overhead to manage a clinic. And let's go back to the stat we said earlier, how much of that overhead can be avoidable, and the third goes to tax, and the third stays with me, right? So obviously, as a clinic owner, all the admin burden that the clinician can face or physician can face, or even they're exponential because you do have to manage on business on that, and there's way more overhead as a business manager. And Dr. also highlights the rising costs of running a medical practices, including EMR licenses, which have increased over time without corresponding increase in billing rate from the Ministry of Health, right? So here is a financial compression due to the administrative task and the administrative burden put on those shoulders. So to conclude, this isn't a story about one physician, right? It is a story about the system consume clinical capacity every single day, right? 1.5 hours a day is not paperwork. It's lost access. It's patient waiting longer. It's undue pressure on our clinician. So this story about Dr. Yu, there's multiplied the number of physicians across Canada by the number of clinic owners. And it's pretty a repeatable story that we hear often when we talk to their clinician on the field. But the reality is clear. You can't do it all either, right? You just can't. It is not enough time, budget, organization, systemic will to make the necessary change, right? Because that problematic is both at the individual level, but also at the organization level and often at the system level. And we'll talk a bit about that later. So as a technology company working with those 1,000 clinician, care provider, and administrator, we've seen that there's actually low-hanging fruit, and that we probably can separate what we can control and really what are those low-hanging fruit as an organization that I can attack and make significant impact over a short amount of time, right? So that's the key here is we need to focus on things we can control in the short term and obviously continue to push and do pressure on the things that we can solve at the system level. And this is where this administrative burden reduction frameworks comes in. So far, we've highlighted the scale of the administrative burden. Like I said earlier, the numbers don't lie, right? And how it neglects untapped capacity and margin hiding in plain sight, right? The question now is how do we systematically unlock that capacity, right? Across ELK system, we found that isolated project and point solution don't solve this challenge. What's needed is a structured enterprise-wide framework. And that's what the one we want to introduce you today, right? It's built on 4 reinforcing pillars. And let's get into it. So the first pillar is operational intelligence and visibility, right? Just a quick, simple phrase is you can't optimize what you can see, right? And this is what we observe in healthcare, meeting especially with the health authority policymaker, administrator, when we ask them, do you really understand the problem at stake, right? So they can understand the face value of the problem. They can express what's happening as an outcome, but they have a difficulty articulating the root cause of that problem. And the reason is simple. They don't have all the data, the evidence to give them, visibility into the root cause of that problem. So just general stats that, got out, last week, which I found really interesting. Healthcare generate globally across the world 30% of the world data. And 80% of that data is unstructured and non-standardized. We're talking about node scan, fragmented record across system. Let's go back to Dr. Wu's story, right? And on top of that, the average hospital runs more than 100 software system, okay? So without a consolidated view of all those infrastructure, those workflow, it is really hard to make an impact. So what we're claiming today is operational intelligence and visibility is the first step for you to understand the root cause of the problem and start solving for it. Data, though, isn't everything. So understanding the problem and making sure you have a standardized view on the data and a great identification of the root cause is not all. Now it's about how do I connect those disjointed workflow together? And often the mistake we've seen is make is we're just going to digitize a broken process. I have this form that I do on paper. I send this fax. What about just digitizing it? I'm going to put it online and then it's going to solve the problem, which is not the case, right? It's the occasion to take a step back. What is the actual job I'm trying to do? What is the end-to-end workflow I'm trying to solve? And what's the best optimal way to solve that problem with all the technology that I have in place, right? And we're going to go a bit into taking that step back motion. But what we're saying here is there's really need to look at the end-to-end workflow, understanding from a physician perspective, not just from an organization perspective, and we try to solve those workflow end-to-end. The third one is super important. You don't want your transformation to lose credibility when impacts take here, right? So performing system integrate quickly. They minimize disruption and deliver measurable gain early. This is super important. We'll go a bit more detail of that. And without too much written replace instability. There's so many change. Most of the hospital are drinking from the fire hose. There's just delivering care, just maintaining operation. You don't want the implementation of new solution in system to disrupt that. So you need to do it as lighter, as seamless as possible, and as fast as possible. And the fourth pillar, not the last, and this is obviously an obvious one, but in practice, not often implemented. We launch a project, we launch a transformation, and we jump to the next project, and we don't measure if we actually achieve the success criteria we were trying to achieve, right? So this is the key, is even in the design phase, trying to launch small pilot to really measure if I'm going to achieve the result I intended. And then post-implementation, when you're going at general availability of your solution transformation, you absolutely need to continue monitor if you're achieving the result you wanted to achieve. And from a ROI perspective and from operational metric perspective, and also from a human resources and well-being perspective as well. So now we're going to dive a bit in each of those pillars in more details. So today, just to be a bit more concrete, right? We're going to give example of what we experienced at Petal in terms of operational intelligence and visibility and the concrete impact it had, on those health delivery organization when we implemented that visibility. Again, I'm going to repeat that phrase. You can't fix what you can't see, right? So this is key here. And we're going to go into what transparent scheduling can do, just improving the real-time availability of their schedule, managing those schedule in real time, and having a consolidated, real-time visibility of all department schedule at one place, just that what it can do in terms of solving a lot of those administrative, burden that's put on the shoulders of the administrator and the physician a lot of the time. And then we're going to go to an example which is closer to the patient, which what you can do when you improve the visibility of patient navigation at large scale. And then after that, we're going to give concrete example what happens when you pair the two. So let's start with the scheduling example, right? Before automation, scheduling, and on-call coordination, and that's a big piece, is the on-call coordination. If it's not in real time, if it sits on Excel somewhere, you don't know if it's the actual sort of source of truth, if the information is up to date. Is that really that doctor that's on call, or is that somebody else that just needed to do a shift swap? and we don't know about it, right? So this is about making sure you have in real time accurate information, just that, right? Before you were relying, but before automation of that process, you're relying heavily on email, back and forth communication, spreadsheet with so many color code. I've interacted with some medical affair group, and they showed me how they manage the schedules in their Excel, and like this is insane. Like they developed like a system by themselves with multiple color code. I don't even know I can achieve that, but they manage it. But obviously not necessarily in real time, and not a way that you optimize the end-to-end workflow, as I said earlier, right? It slows the decision, increase the administrative load, and in many organizations, this translates into thousands of hours, and we measure that annually spent simply coordinating coverage, just making sure everybody have full coverage. We've documented that we're talking here about 4,500 hours saved yearly, right? Also, another statistic is 98% faster schedule creation. This is huge, especially for the medical affair group or the planner in each department, the physician that's been asked to provide the schedule for his group. And a 92% satisfaction score when you automate that process from end to end. And also a 70% cost in reduction just by automating also that process. So this is a concrete data points that we've measured to a third-party firms, just by improving small, like we were talking about low-hanging fruit, just global visibility on your coverage and the ability to manage that coverage in real time. Just that visibility saves a lot of hours just by itself. If we go back to the other example, which I was talking earlier, which is closer to the patient, is when you put yourself in the shoes of the patient and you're trying to access the care, first, it is really hard where you can go. It is really hard to know where you can go. Often you're going to call 811, they're going to try to direct you, especially in a primary care sort of episode. You're going to walk into the clinic. You don't even know if if you could have been served at the pharmacy potentially with the extended scope practice. You don't really know at a larger global level what's the available care for you. And the reason, again, is because this is just a collection of disjointed systems, right? So it's really hard if the system itself cannot know where its availability lies and where you have choke point, where you have capacity issue, where you have surge in demand versus other area where you have bigger capacity and less demand. Imagine the patient side, I was going to be able to navigate it, right? If as a system yourself, you don't even have visibility and sort of the complete ecosystem. So, and this is pretty obvious. The EMRs, when you look at the Canadian market right now, are not speaking to each other. Most of you must have heard the news of Ontario, what they're trying to do in Ontario and harmonizing at the EMR level to have sort of a single point of record. This is a good step forward, but obviously it doesn't solve all the problem. There's many systems, the booking portals, the call centers, the provincial validation systems, the referral list, and the provider scheduling system, which are all disjointed right now. So again, going back to going to a policymaker or health authority administrator, when we asked him, do you understand the problem that's at stake or the root cause? It's very hard to understand with that information scattered across the system and not a unified view of what your root cause is. Once you connect those systems together and making sure that the patient can access care based on the rules, on the program that are in place within the health authority, that's where you talk about a real-time health system, where the patient journey becomes connected and visible, right? The referral are routed intelligently, appointment aligned with true capacity, and confirmations happen seamlessly. And care is delivered without unnecessary friction with the data required to provide that care. So this is what we've been able to achieve concretely in Quebec. So for people who doesn't know, in Quebec, every citizen that want to access primary care is going to go through a portal owned by Petal, and we're going to direct the patient to the complete ecosystem, and we're going to direct them to the most relevant appointment within the best time that we can find based on this condition that he's providing. And that led to concrete saving. So one of the key use case we've been able to solve with that, and we have data points since 2022, is the capacity to redirect patient from emergency department to a primary care clinic when it's a low acuity instance, right? So we've been able to measure over those 4 years, 8.7 reduction in low acuity visit that have been able to redirect to primary care clinics. That's mean more than 800,000 ED visit over that period, accumulating to $339 million just in saving, just by being able to connect that ecosystem together and making sure the patient can navigate across that ecosystem properly and more efficiently. Number two, the pillar number two that we talked earlier, it's good to have visibility. And the latest example is a bit on the fence between the both, right? So that patient navigation example, not only have we been able to create that system-wide visibility, but we've also been able to fix a broken workflow, end-to-end broken workflow for the patient when he's trying to access primary care. The other angle at this workflow orchestration, if we go back to within an hospital, is there's a huge cognitive burden that is put on our clinician, right? And it really decreased as we said earlier, it really has an impact on the patient throughput and the patient quality of care, right? And we realize there's so many little tasks, just with scheduling and billing workflow alone that can be avoided. So just there, you have some low-hanging fruit that you can attack right away and help save a lot of those, red tape and unnecessary administrative tasks. Without going through all the people and the activity that are concerned, just when we talk about scheduling and billing, but it ranged from the clinician having to track work for billing, submitting his billing code to the insurers, to the administrator reconciling, scheduling and billing data, especially in alternative payment model, to the scheduler and coordinator fixing conflict across the system, adjusting the shift for billing accuracy, to a group head making sure you have full coverage and resolving the staffing and billing gap. There's so many activities, and most of these activities can be automated. It doesn't need to be manual, and that's the key here. They shouldn't be manual. They shouldn't put the weight on the clinician, on the administrator, on all those persona. We should put the weight on them to do that manually and suboptimally. This is can be easily automated, and as proven again by third-party studies, we've measured up to 98% reduction in schedule creation time, right? So let's go back to that 19.8 million, hours that we're trying to save. That is avoidable. This is a big part of it. It's just avoiding those small clinical burden, those small low-hanging fruit that can be attacked pretty quickly. And this is just from moving from a Excel system to a low sort of impact digital scheduling system, just that, can create a lot of change. And this is structural change. This is just not a one-off, right? So this is just a concrete example where just by automating the schedule creation and automating the process end-to-end, the amount of time you can save. We're talking here, again, more than 8,000 hours annually, just the impact of having a real-time on-call management tool integrated with your scheduling. If we jump to the billing, billing isn't just paperwork. It's a complex chain of reporting, approval, rejection management, reconciliation, and compliance oversight. Each of those steps require manual review, interpretation, and follow-up. That creates cognitive drag at the individual level, operational inefficiency at the department level, and financial variability at the individual and network level, depending on the compensation model in place. And we've seen examples of doctors sharing that because they've been billing the wrong code for many months, the insurers come back to them, ask them that they owe them 45,000 or sometimes 30,000. We heard a lot of those stories where they're being clawed back on their revenue as an individual. And imagine people owning a clinic, and let's say all the doctors on the clinic have been billing that wrong code, how this can become exponential in terms of impact. So it's not just the administrative burden of doing your billing, but that, am I billing the right thing? And am I going to have an impact on my financial stability in the future because I haven't billed the right thing? And they also want to make sure they get their fair due. They're working hard, so they do want to make sure they bill everything they've done as a service. So just based on the study again, so Petal is a major medical billing software provider across Canada, and based on the many years of the history we have in that business, we've been able to measure a 9.4 average revenue increase just by providing a more efficient billing tool. meaning that it capture all the billing code, ensure the doctors capture all the code. It has validation, it has suggestion, just that major improvement in revenue increase. And also 161 hour per year save on average just on the time spent versus manual billing. So again, two sort of dimension here: financial stability, the cognitive load of making sure you're having your fair due and not being clawback in the future. And then the other side, saving a lot of time just doing that process of medical billing. And now the third pillar, which we talked about earlier, it's accelerated value realization. It's good to have all those good ideas, but if they take 2 years, 3 years to implement, if they cause more disruption than gain, this is not advantageous. I think in health, in all industry, but we've seen it a lot in healthcare. We often underestimate how much time goes lost between implementation and real world adoption. And especially the key here, what we've seen, and you need to bring your clinicians and the co-design phase. You need to bring them up. The people that's going to use your solution need to be in the solutioning, need to be in the co-design. We saw a lot of implementation where it's been mainly designed, let's say at the health authority or administrative level, and was not really aligned with the reality of the field. And that caused major disruption, no adoption, and all the saving you've been planning goes to waste just because you haven't had the right advocacy and the right people, solutioning with you. And that's something we do a lot in product, is really making sure that the user are part of the solutioning, are part of the design. This is key. This is how you're going to get, measurable outcome very quickly. But also you're looking at systems that don't do big rate replace, that system that enhance your existing ecosystem versus disrupting it. Obviously a system that can integrate well with your EHR because they're your core, or EMR in the primary clinic because they're your core operating system. So you want a system that really integrate, and more if you can have a system that's more of a platform where it provides multiple capacity at one place versus having to deal with multiple solutions. This is all small things that can help you get the accelerated value realization, and what we say, get a better time to value in terms of transformation project. Again, I think I've covered most of that. Team training, change management, really planning the sunsetting of your legacy system as well. Like, how am I going to remove the existing system versus the new when it is a rip and replace scenario? Or how does the new system, how does it change my end-to-end workflow, right? How does it create impact I haven't seen? And I'm going to create, actually more burden on one side versus I'm trying to solve the other side, right? So it's really keeping that holistic view of your system, of the workflow, and making sure whatever you implement as new, at net new, does improve the overall system and doesn't put a strain on it. But time to value is super key. I don't think it's going to be a surprise to anyone here. And then let's jump to the details of the fourth pillar, which is measuring what you've done. This is the last step, the most important step. I'm not going to go too much to it. There's a lot of documentation on how to measure, success of a project. But it is the most important piece. You want to make sure you realize, you want to make sure you haven't made a mistake. It's really rare, and I've been in product for 15 years, that the solution you're going to design upfront will solve the need properly. It's going to need iteration. It's going to need some fix. And if you're not measuring the impact, it's really hard to have visibility on what you should be improving. And that's where sort of your ROI, the business case you've been promoting at the beginning, sort of not go to waste, but is not giving the result you want. And also you create disengagement with the clinician, create disengagement with the workforce. It's the last thing you want to do, right? So measuring, making sure you have a strong handle post-implementation on the result that their solution transformation is bringing is key. Another way which I like to look at it is, and just like a thought-provoking thing, is if you take a step back and you look at what you could achieve at full capacity, right? Let's say you run full efficient, like, F1 pit crew, right? For 24 hours, 7 days a week. What would be your maximal achievable throughput in terms of capacity, right? In terms of treating patient, define that measure, and then compare it to your actual throughput. And this becomes very interesting because now it's forced you to understand, okay, but what's the gap between what I should be able to achieve at a maximum efficient level, and what am I not achieving, and then really start to measure, those layer of system of capacity leakage, and then help you identify the largest one, or sometimes it's not necessarily the largest one, it's the one that you can fix very quickly with a very quick impact, as we said earlier. But it goes back to having that visibility of what are my main challenges, where is my capacity leaking, and what is the first thing I'm going to prioritize in terms of solving that capacity issue. As I said earlier, we've provided you concrete tips that are very close to the clinician, very close to the organization. We've talked about scheduling, billing, and then we also talk about a bit of our system level use case with patient navigation in primary care. It is important when you think about it to take a step back and look at the forest and not just the tree. There's obviously a lot of the issues created by administrative burden are systemic. They're a combination of clinician, HDO, policymaker, and insurers. So this is often a mistake we do when we go into transformation. We look at it just from the lens of our organization, especially if we touch a physician workflow. Whereas the physician sometimes is going to work in multiple organizations, is going to be impacted by other, body organizations such as the insurers. And we really need to look at the end-to-end workflow of those physicians, of those clinicians, to really understand where the choke point. And sometimes it is not within your organization, and you're not going to get the ROI we just spoke about if you haven't did that sort of end-to-end mapping of the problem and the workflow. And I'm losing the time here. I know we're short on time. There was some concrete example. I'm not going to the detailed example, but just a very quick example is just in Ontario, we had a lot of physicians sharing how much painful it was with the health insurance card when it changed version. That version number and insurance card can change for many reasons. If you change addresses as a citizen, other reasons is, and then if the health delivery organization has not been able to validate via the clinic hospital level that the healthcare insurance was the version numbers were up to date, well, what's going to happen is the physician is going to bill to the insurer. The insurer is going to refuse the claim because the health insurance card is not up to date because of that version number. And then what happens to the physician? He's stuck with him chasing that money, making sure, find back the right health insurance number. And it's the only way for him to get his money. So here, not only does he has revenue at risk, he's losing all this time just to chase that rabbit of finding that version code. And more often than not, what it ends up to be is he's not getting his revenue back, and he did lose the time anyway to chase. And most of them just abandon right off the get-go because they know they're going to get it back. So it was just a concrete example where those four organizations together, if they not work together, can create those friction point. And again, cognitive burden and financial strain on our clinician force. So now we've gone through those four steps. I think most of the audience must be familiar with our ROI calculation. What we wanted to do is just give you some concrete example of what we've done. So again, in terms of the scheduling automation saving, we've measured with 20 group, right? What was the saving over a period, per year, over a period of many years? And what happened is we figured out there was 267 hours saved per group per year, multiplied by those 20 group, and that sum up to that 4,295 hours saved annually, right? So just a concrete ROI calculation. Same, this one is very impressive. We didn't, we underestimated the time it takes just to search for who's on call, right? That clinical visibility and sort of coordination we talked about. We've measured that actually, there's an average per year of 100 search by physician. And this is conservative. So take 500 physician, right? And, there's also 1,000 non-physician clinician that does 100 search per year. And we estimated very conservatively a minute, that is served per search. But we have concrete example that the search sometimes take 3, 4, 5 minutes. And just automating that real-time visibility and automating that search equated to, $1 million saving, per year, which is just, for me, was fascinating. We didn't anticipate that. So again, going back to that low-hanging fruit, sometimes we think of the big things, but there's small thing we can fix and provide some very quick return on investment by fixing it. The billing optimization, I've talked about it earlier. This is very easy to measure. It's basically the number of time you can save over a number center physician. When we take 161 hours saved per physician per year, we take 500 physician. That's 18,000 hours saved annually. Again, chipping away at that 19.8 million we talked about earlier. These are all small things that we can do to chip away that number. And that's a concrete example here. Not talking about the revenue the doctor can making sure that the doctor gets his fair due as well on the side. So what we're trying to say at the end is, right, the compounding ROI via workflow optimization is real. It's really, again, we look at the end-to-end processes, the workflow, both from a scheduling efficiency, coordination efficiency, billing time reduction, and sometimes even scheduling intersect with billing in some, we talk about the mocap report, the on-call reporting, compensation. And, it is translated. It does compound a lot when you just, sort of, increment those solution together, put them together. It does compound in major savings. And that's your claim today. If you take that framework, right, of understanding, your operational visibility, how can you scale that automation, making sure you can implement those change very fast, and that you can measure those change. If you combine all of that, it compounds very quickly. Okay. So that's how I would like to end the webinar today. I guess at the end, what we're all aiming for, by reducing the administrative burden is a more sustainable and high-performing care model. I think we provided concrete example today, but just with those three examples, what I want you to take away, we just provided you two concrete, very discrete example of saving we can achieve in terms of hacking away at those, avoidable administrative hours spent by clinician. Think of, you can multiply those initiatives by 10, 15, 20, right? And you can compound those small, low-hanging fruit, the impact you can have on the system. We know the divide between, as I said earlier, the divide between the clinical capacity and the demand is growing. So we need to find way. We don't have a choice to find way. And I think we're losing time right now. We don't have enough time to sort of bring that divide, solve for that divide. We cannot avoid to waste hours in avoidable red tape or administrative tasks. So I hope today it gave you some concrete elements that would help you. Obviously, this is a very loaded topic, so it's hard to sort of cover that topic within a 30-minute framework. But that's how I would like to end. Hopefully it was helpful, some concrete insights. And I'll end it up to Madison, for the Q&A session.
Awesome. Thank you, Yan. We do have a few questions in the Q&A, but if anybody has any further questions, please feel free to put them in the Q&A or the chat, and we will get to those. Kind of starting off, we do have a question from David. So he kind of brings up that the healthcare system is already financially overburdened, which we all know, and this tool does increase the cost of care by 10%. So how do you see this increase in cost of care as adding value? So what are kind of the positives to the publicly funded healthcare system?
That's always a challenge. And I think if we go back to the pillar earlier, is if you don't have a strong ROI business case and you cannot prove that you're going to achieve, compensate for that cost with concrete cost saving and efficient, right? Within a short time frame, it's going to be hard to sell because we know the budget are constrained, right? So we have to go back to that, the ability to measure what that saving represent, build a strong business case on the real saving you're going to get from that implementation, and then what is the time frame you're going to add the saving. This is the key element. As in any business, it's in healthcare, especially with that budget constraint element, it's go back to that. It's have a strong ROI, and I know sometimes the budget unfortunately is not there. Like the saving you get from the initiative from a time perspective doesn't coordinate with the budget. So the saving you guys gonna get later. So that's why the time to implement is key as well. So sometimes it's about doing a small pilot, very low cost my pilot, proving not necessarily a pilot, but a sort of a limited implementation, and prove the ROI concretely with those efficient gain, and then prove that your the complete ROI will be achieved within the time frame you want and what you want to solve for. So that's what I would say, if that makes sense.
Absolutely. And then we have a couple of questions here about the ROI. So Tammy asks, how do you calculate your ROI for hours saved?
So basically, it is very detailed. As I said earlier, it is a detailed third-party analysis that's been done. They've done group comparison. So group that have been doing manual scheduling and console, not console, but the sort of on-call coordination. And they've been comparing to group that have been using the fully automated processing tool. So that's how they went about. And then they compare the two groups. What is the amount of hours saved when you're on the sort of more automated process versus when you're more status quo legacy process. And that's how we came up with the saving. And that's usually a good way, when I said earlier, to go back to your other question, is when you do that sort of small scale implementation, is exactly doing that, is comparing those groups. And then you have tangible proof that you're going to get ROI out of that transformation project.
Perfect. And then we have another question here from an anonymous attendee. How do you determine maximum ideal capacity in already overburdened systems?
No, and that's what we're trying to achieve. I think it was a thought-provoking things, right? What if we could measure that? I actually don't have the answer on how we would measure that, but I would be really interested to do it because it sort of it brings the conversation to the right level. Allow us to take the step back, look at the forest, not just the tree, and what are the real things we're trying to solve here, right? And we're often, and it's like that in every business. We're often there's a problem surfacing, we're trying to solve it, we go with a solution quickly, we don't even try to understand the root cause of that solution, and solving too quickly, and what happens there was not really solving the problem and its root cause, not getting the ROI, the success we were wanted. So yes, I would like to be able to do that, but I don't have the magic answer today. But if somebody have ideas around to do that, I would be really interested. Yeah.
Absolutely. And I think just kind of further to that comment, this person kind of states that it's hard to assume that these hours are being immediately returned to the
Correct.
system when physicians already suffer from poor work-life balance. So kind of just
Correct.
the idea that that needs to be restored. That's what this person was getting at. Yeah.
And that makes total sense. And again, that's why we said, and if remember, yes, there's the hours you can reinvest in patient, and providing care, but it's also in time you can reinvest in the well-being. Whatever the physician want to achieve, if you want to achieve more work-life balance, or whether you want to achieve more patient care, that is key. But like the impact of a physician not being able to achieve that work-life balance is huge on the sustainability of care as well, right? So it's harder to measure, but we know it's there.
Absolutely. And I don't think we have any more questions right now. I'll put out a final call for any further questions. We do still have a little bit of time. Um, but until then, I see you have on the screen your QR code there, Jan, for any of the further
Right.
details, and
Yes.
also your email is on there as well. So if anyone has any further questions, I'm sure you can contact Jan as well.
Correct. And we have the details on the studies that the numbers of the study I showed. We have all the detail, the methodology. So if you're interested in that, we have a lot of material for you to really do a deep dive on how we can achieve those sort of ROI analysis. So please reach out if you want to know more about those initiatives.
Absolutely. And I'm not seeing any further questions. So I think with that, we do have still a little bit of time left, but maybe we'll just get a little bit of time back in everyone's day.
I think people will take
And
it.
yeah, I know with the
On the
time of the
topic.
year.
Yeah, it's on the topic.
Absolutely.
Perfect.
All right. So with that, I will say thank you very much to Jan and to Petal Health for sponsoring the industry showcase today. It was an amazing presentation. And again, if you have any further questions, please feel free to reach out to Jan, or you can also reach out to myself and I can try and help connect you guys. And with that, just a couple of last minute Digital Health Canada things. You will see on the screen here, we have a QR code of our own. This is just the QR code to the short questionnaire that will be sent out to all attendees by email anyways. But if you would like to just go ahead and scan the QR code on the screen now, we encourage you to take the 2 or so minutes that it will take to complete the survey. We do love to hear your feedback, and we really like to take it to help shape our future industry showcases. So please, we do encourage you to do that. Again, I will send out an email to everyone, so you will get it by email as well, but feel free to scan on the screen as well. And then we'll also, while we are at it, do our satisfaction poll, which you'll see on the screen. It's just a quick 1 to 5. How satisfied are you with today's webinar? Again, we'd love to hear your perspective, so thank you. This is just a quick snapshot. The survey is a little bit more. If you have any further comments, we would love to hear that as well. But thank you for taking the time to do the satisfaction poll as well. I'll give another maybe 5 or 10 seconds. Awesome. Thank you guys very much. And then our last thing before we go, we have our upcoming events, which we just have one at the time, as we did have, we did have our Ontario conference last week. So if anybody was there at the Ontario conference, thank you for coming. We do have our eHealth 26 in June 14th to 16th, which will be in Halifax this year. Registration is open for that. So please feel free to head over to our website and register. For anybody that is a member, you do get a member's discount. So if there are any non-members here today, maybe consider getting a membership and you can get some discounts to our events. But other than that, that is all from me today. I want to once again thank you, Yan, and thank you, Petal Health, for sponsoring. And thank you all for joining us today. And I hope you have a great rest of your day.
Thank you, everyone. I appreciate the session.